Hi, so welcome to the second part of Train Your Brain series, friends. We are going to be having a discussion about more clinical presentations which are going to be given in your exam and the likely diagnosis that you're going to be encountering in the options, right? Starting off with the clinical presentation of a patient having the presence of a fever, vomiting, diarrhea, and a desquamating rash, particularly after the use of a nasal pack or after the use of a sanitary tampon. So when you look at this kind of a presentation, this is very much suggestive of the patient going to be having a condition that is going to be given the name of toxic shock syndrome toxin. And this is going to be because of a bacteria that most of us are familiar with. This is going to be because of staphylococcal infection. What do we need to remember about this kind of a toxin? You need to recall that this is an example of an exotoxin, which is going to be functioning as an example of a super antigen. Now, super antigen would be associated with the release of cytokines in a massive amount, and this is what is going to be responsible for the downscale course of this patient in a short span of time. So, classical history, after the use of a nasal pack or a sanitary tampon, patient having a development of toxic shock syndrome. The next one talks about a patient who's going to be having the presence of a strawberry tongue. The moment the question is going to be making a mention of strawberry tongue, two things would be coming to your mind. One can be in the differential diagnosis, you can be thinking in terms of what is going to be given the name of scarlet fever, right? The second thing which is going to be coming to your mind is going to be, in case of children particularly, we are thinking in terms of a condition that is going to be given the name of Kawasaki's disease, right? So there is a possibility that both of them can be given as options in the exam. Now, in a patient who's going to be having scarlet fever, you're going to be having the presence of a rash. Now, may I just remind you of the fact, what kind of rash would you expect to have in a patient having scarlet fever? Yes, you are aware. The patients are going to be having the presence of what is going to be given the name of a sandpaper rash. Sandpaper rash. Whereas, the moment we are thinking in terms of a patient who's going to be having Kawasaki's disease, patients having Kawasaki's disease classically are going to be having the presence of fever. The other important thing the patients are going to be having is presence of lymph node enlargement. Typically, this is going to be unilateral cervical lymph node enlargement. Patients can also be having the development of non-purulent conjunctivitis, and they could be having the presence of other manifestations, for example, edema of hands and feet. Why I am talking about this particular condition also is because the fact Kawasaki's is one of the few conditions in which a child is going to be having the presence of a fever, and yet you are going to be giving a drug like aspirin in this child. Please recall the fact that aspirin typically is to be avoided in case of children having fever, because in viral fever, if a child is being given aspirin, it can result in severe mitochondrial damage, a condition that all of you are aware is given the name of Rey syndrome. But two conditions where a child is having the presence of fever and aspirin is still given, one of course is example of what is appearing on your screen, Kawasaki's disease. And can you recall for me the second condition? Hanji, the same condition in which you are going to be having the presence of migratory polyarthritis. That means a patient who's going to be having the development of rheumatic fever, right? Talking about the next one. Patient having a presentation of fever, cough, coryza, conjunctivitis, there is presence of diffuse rash, and the question can make a direct mention of the fact that there was a presence of something like Koplik spots, or the newer way of testing this information in the exam is they will make a mention of small irregular red spots on the buccal mucosa which are going to be having the presence of blue-white center. The moment we are talking about Koplik spots, they are going to be having the location opposite the second molar tooth. So apart from the cough, coryza, conjunctivitis and the rash, this is what you need to be keeping an eye on. And if I'm talking about the presence of Koplik spots, of course, the first thing that would be coming to your mind is going to be the patient is going to be suffering from a condition that is going to be given the name of measles. Now, with regards to measles, what they are asking in the exam as a part of a histopathological images, that patients who are going to be having the presence of measles on the histological examination would be having the presence of a special type of a giant cell. What giant cell are we talking about in case of patients who are going to be having measles? Yes, you are right. They are going to be having the presence of what is going to be given the name of Warthin-Finkelday giant cell. So, Warthin-Finkelday cell is what you are going to be seeing in a granuloma in a patient who is going to be suffering from measles. That is what is to be kept in mind. The next one talks about a patient who is going to be having the presence of a systolic ejection murmur, which is going to be having a nature that is what is being described in the question as crescendo and decrescendo murmur. And typical words mentioned in the exam question can be pulsus parvus et tardus. Now, that can be a very, very important hint in the exam question. Or the way it was given in the NEET PG exam was the patient was having the presence of syncope, he was having the presence of angina, and there was presence of dyspnea on exertion. Now, this kind of a combination of syncope, angina, dyspnea, exertion, and the presence of a crescendo-decrescendo murmur, or the mention of the term pulsus parvus et tardus, is what is going to be associated with the presence of a valvular lesion. And what kind of a valvular lesion are we thinking in terms of over here, friends? We are definitely thinking in terms of a patient who is going to be having aortic stenosis. So, this important fact is what you need to remember. Another important kind of a cardiac valvular lesion would be making a mention of the patient having the presence of hyperdynamic pulses. That itself can be one important hint. Or the question can make a mention of a wide pulse pressure. Now, presence of a wild pressure, or you can be having the presence of early diastolic murmur. Typically, it is going to be having the presence of a decrescendo nature. And the question can be having the presence of other manifestations, which include the classical signs, including what is going to be given the name of head bobbing. So when you are going to be having the presence of a wide pulse pressure, there is a presence of a hyperdynamic pulse, there is a presence of a head bobbing. Yes, I'm thinking in terms of a valvular lesion, and this kind of a valvular lesion is what is going to be given the name of aortic regurgitation. Aortic regurgitation, right? Another thing that is to be remembered over here is with regards to the cardiac valve conditions over here, any kind of a condition in which there is going to be a presence of a regurgitation on a stenosis, or if there is going to be a presence of a degeneration of the valve, typically is what is going to be associated with the development of calcification, which is going to be given the name of dystrophic calcification. And one of the reasons of having a development of a dystrophic calcification in our country, that means under Southeast Asian conditions, is to be remembered as the patients who are going to be suffering from a condition like rheumatic heart disease. Talking about the next one, and the which question is going to be making a mention of a child who is going to be having the presence of, and that's a keyword, continuous machine-like murmur. Of course, if I'm thinking in terms of a continuous machine-like murmur, what you are going to be thinking over here is going to be an example of a condition. This is what is going to be given the name of, yes, you are very right, friends. This is going to be given the name of patent ductus arteriosus. Patent ductus arteriosus. Now, two questions which are going to be pharmacology links over here with regards to patent ductus arteriosus. What chemical is responsible for maintaining the patency of the ductus arteriosus? So, patency is going to be maintained with the help of prostaglandins. So, prostaglandin analogs are given to the patients to maintain the patency. But what is an example of a drug which is going to be responsible for medical closure of patent ductus arteriosus? That's simple. If prostaglandins are responsible for maintaining the patency, and you and me know that prostaglandins are coming because of the action of COX enzyme, then I will simply block the activity of the COX enzyme. And COX inhibitor specifically given for closure of the patent ductus arteriosus is very good. You know the answer, and the answer over here that you remember over here is indomethacin. In fact, very few examples of painkillers are going to be associated with specific indications, and indomethacin is one classical example that you need to remember for which cardiac condition it is useful for closure of the ductus arteriosus, which has been patent, right? Talking about the next one. Patient is going to be having a clinical presentation, classically given as a medicine question, which is not going to be as simple, but is fundamentally on the basis of the presence of chest pain on exertion. You see, there can be two types of situations. One is the patient is going to be having the presence of what is going to be given the name of angina. And in context of angina, what is going to be seen in the patient is going to be the discomfort is typically going to be present on exertion. Discomfort on exertion. So the question can make a mention of the patient who is going to be climbing up stairs, or the patient is going to be engaged in a physical activity where he is going to be a long-standing hypertensive or a smoker, and he is going to be going in for a jog, and exertion is what is going to be precipitating the pain. The other situation can be the patient is going to be having the presence of what is going to be given the name, and this one is going to be stable angina. The other one that I wish to talk about over here is a condition that is going to be making a mention of unstable angina. Now, unstable angina is a situation in which the patients are going to be having the development of vasospasm, and this kind of a vasospasm is going to be typically associated with some kind of an ulceration of the plaque as well. So, typically what is going to be seen over here is the discomfort in the patient over here. The discomfort in the patient over here can be present even at rest. So, whenever we are talking about the presence of chest pain on exertion, which is stable angina, there is going to be an increase in the physical activity, the pain is going to increase, the discomfort increases, and whenever there is going to be the person taking rest, the discomfort comes down. But in case of unstable angina, the pain is going to be much more severe, and the pain keeps on increasing even after the patient has taken rest. So that is a keyword that is to be remembered. The other important thing that you need to remember is the question making a mention of a patient who is going to be having the presence of chest pain with ST segment depression on the ECG. The moment we are thinking in terms of a patient who is going to be having the development of ST segment depression on ECG, this is what is going to be associated with either the presence of angina. It can be a situation when the patient is going to be having the presence of angina, or this could very well be a patient who is going to be suffering from non-ST elevation MI. Now, why do I say it is non-ST elevation MI? For the simple reason because the patient is not having ST elevation, he is having the presence of ST depression. What is going to be useful for differentiating between these two conditions? Classically, if it is a case of a patient who is going to be having the presence of an angina, then obviously the cardiac troponin levels over here are going to be normal. They are not going to be raised. But if my patient is going to be having the presence of non-ST elevation MI, that means the cardiac troponin levels are going to be increased. So depending upon what exactly is going to be given as an additional finding in the patient, you are going to be marking your answer for the question. Please do be familiar with the fact that am I going to be giving a thrombolytic therapy in a patient who's going to be having NSTEMI? The answer is absolute no. You are not going to be giving a thrombolytic therapy to a patient who's going to be having non-ST elevation MI. What is a drug to be given to a patient who's going to be having angina? And most of you know the answer. वो वाली दवाई जो आप जीभ के नीचे रखते हो, sublingually given drug, that is going to be given the name of nitroglycerin. Why are we giving nitroglycerin by the sublingual route, by the way? For the simple reason that you are avoiding the first pass metabolism, and therefore you are going to be having faster onset of action of the drug, right? So those are the things that you just need to keep in mind. Talking about the next one, in which the patient is going to be having the presence of a chest pain, there is a presence of pericardial effusion, or the question will make a mention of the presence of a friction rub. The patient is not feeling too good, that means he's having malaise. The patient is going to be having fever, and this can be following weeks or sometimes days or sometimes even months after an MI. So post-MI, patient is having fever, malaise, pericardial effusion or pericardial friction rub, or he's going to be having the presence of a chest pain. Of course, you can understand the fact trends that it is going to be associated with exposure to new antigens. And when I'm talking about the new antigens, this is going to be classically an example of an autoimmune reaction. And this autoimmune reaction is what is going to be associated with the development of pericarditis. So autoimmune pericarditis, which can be seen as early as few days after myocardial infarction to typically 2 to 3 weeks after myocardial infarction, and uncommonly it can be seen after several months as well. This is what is going to be given the name of an autoimmune pericarditis. And I hope you can recall for me what is the technical name given to this condition. This condition is going to be given the name of Dressler syndrome. This condition is going to be given the name of Dressler syndrome. So just be familiar with that particular fact. Talking about the next one, the patient is going to be having, now this one is easy guys, distant heart sound. The patient is having distended neck veins, and the patient is also going to be having the presence of hypotension. So we are talking about a very, very classical triad over here. Fact number one, what is the name of the triad? Yes, I know, you know the answer. This is going to be very good, Beck's triad. The second can be a one-liner question. Where exactly do we talk about a Beck's triad, guys? Beck's triad is going to be associated with a patient who's going to be suffering from a condition that is going to be given the name of cardiac tamponade. And I don't want any of you to miss out the classical crucial differences between the cardiac tamponade and constrictive pericarditis. The one which is going to be having the presence of a rapid X descent, another one having the presence of a Y descent, and the beautiful table that you read about in medicine. But don't forget the basics. At least you should be familiar with the concept of the Beck's triad in association with cardiac tamponade. Talking about the next one, patient is going to be having the presence of painful, big time hint, patient is going to be having the presence of painful, purplish or reddish lesions which are going to be present on P for pads of the fingers and toes. So 3 P's which I want you to remember, it's painful, it's purplish red in color, it's present on the pad of the finger and toes. And the moment I'm going to be talking about this one is, this is going to be an example of a painful lesion. So of course, you know, when there is a pain, we remember it as it's ouch, the patient is having a pain, ouch, that means O. And therefore, what you're talking about over here is the presence of oscillar nodes. Now, why exactly do we have the formation of the oscillar nodes is something that you're aware of. You are having a patient who's going to be suffering from a condition that is given the name of infective endocarditis. What explains the pathogenesis of the oscillar nodes? Oscillar nodes are typically going to be produced because of the deposition of the immune complexes. So in that context, I want you to recall it is an example of a type 3 hypersensitivity reaction manifestation. Immune complexes are responsible for the development of oscillar nodes, and they are going to be painful. The other one is what is going to be bringing a smile on your face. Similar type of a patient having the presence of a painless reddish lesion which are going to be present on the palms and soles. So when there is going to be no pain, painless lesions on the palms and soles, again, I am dealing with a patient suffering from infective endocarditis. This is what is going to be associated with no pain. So no way there is a pain, no way, Jane way, no way. You're going to be making that question incorrect in the exam. Janeway lesions. The way I remember it, aapne dhyan rakhna hai, no way there is a pain, some painless lesion that is going to be seen. What exactly is the reason for the development of this kind of a Janeway lesion? Of course, you're aware, I am having a patient having infective endocarditis. So this patient is going to be having high chances of development of embolization. And because of the development of the septic emboli, or there could be a possibility the patients could be having the presence of a microabscess, they are going to be having the development of these painless lesions. So when it is painful, it is ouch, oscillar. When it is painless, it is going to be Janeway lesions. And of course, I believe that the pictures of those would be immediately come into your mind taking care of this condition. Talking about the next one. Patients are going to be having the presence of splinter hemorrhages. Now, this is going to be a Medicine question, as well as this is going to be an opthal question. Splinter hemorrhages in the fingernails, or the question can make a mention of a direct mention of rot spots. With the current trend, they may not be giving the word rot spots. भाई बहुत ही आसान हो जाएगा फिर तो question. तो आपको क्या देंगे exam के अंदर? Retinal hemorrhages which are going to be having the presence of pale centers. And what is going to be the likely diagnosis? Of course, I am again talking about rot spots. This is going to be seen in a patient who is going to be suffering from infective endocarditis. The microbiology component also here becomes very, very important. The moment I am thinking in terms of infective endocarditis, acute infective endocarditis is associated with which bacteria? Typically, this is going to be because of Staph aureus. Subacute bacterial endocarditis is going to be associated with which bacteria? It is typically going to be the alpha hemolytic streptococcus, that means Streptococcus viridans. We are thinking in terms of a patient who is going to be having the involvement of the right-sided cardiac valves and he is having infective endocarditis. That means we are typically associating this with a patient having a history of intravenous drug abuse or a patient who is going to be having the presence of, HIV positive, again because of the entry of the virus into the venous system because of the illicit abuse of the needles, right? So keep those things in your mind so as to take care of these questions in the exam fairly easily. Whenever I'm going to be talking about the next presentation, this can confuse you at times. It's a very important distractor. Patient having the presence of telangiectasia and skin discoloration. Patient who's going to be having the presence of recurrent episodes of epistaxis. Patients having an AV malformation, and as an extension of this manifestation, patient having a GI bleed or patient having a hematuria. So when we are talking about this kind of a condition, we are dealing with a patient who's going to be suffering from what condition? This is classically going to be hereditary hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia. And the other name given to this condition, that is where the people will tend to confuse you in the exam. इसका आपने दूसरा नाम याद रखना है. कौन सा syndrome की हम बात कर रहे हैं? Very right. Osler-Weber-Rendu syndrome. Osler-Weber-Rendu syndrome. This was a classical INA question which was given in the exam. So they can be writing the name as, या तो इसका नाम लिख सकते हैं HT, HST, that is hemorrhagic hereditary hemorrhagic telangiectasia, or the question given in the exam can be OWR, that is the Osler-Weber-Rendu syndrome. Combination of the presence of telangiectasia, combination of the presence of a patient who is going to be having a GI malformation, because of which the patient is having a GI bleed, AV malformation causing the same thing, and that is exactly what is also responsible for the development of epistaxis in the patient as well. Talking about the next one. Patient is going to be having a classical presentation of unable to lactate postpartum. Big time hint. This lady, unfortunately, is not able to have normal menses. And she is also having the presence of something like cold intolerance. No, the first two are given a separate question in the exam. Post-pregnancy, she is not having her resumption of the period. She is not having the development of a lactation. This could be because of what is going to be given the name of a syndrome. This syndrome is what I want you to remember, friends. It is given the name of Sheehan syndrome. Now, what exactly is the problem in Sheehan syndrome? This is a separate question that is being given. In Sheehan syndrome, the problem over here in the patient is that because of the pregnancy, the patient is going to be having the presence of postpartum hemorrhage. And this postpartum hemorrhage is so severe that it is responsible for the development of infarction of the pituitary. So, severe postpartum hemorrhage contributing to the pituitary infarction is what is seen in a patient who is going to be suffering from Sheehan syndrome, and that is why the patient is unable to either menstruate or she is not able to have a proper lactation, and that is what you need to remember for exam question. The next one makes a mention of a broad term in which the patients are going to be having the presence of heat intolerance, there is a presence of weight loss, there is a presence of palpitations. Now, when we are talking about the presence of heat intolerance, when you're talking about weight loss, when you're talking about palpitations, and there can be increased sympathetic activity in terms of fine tremors, or there can be hyperreflexia. Increased sympathetic activity along with an increase in the BMR is what is very much suggestive of a patient who is going to be having increase in the thyroid activity. And if I'm talking about the increase in the thyroid activity, I would be obviously thinking in terms of a patient who is going to be having hyperthyroidism. Now, with regard to hyperthyroidism, of course, you are aware that this could be because of an autoimmune problem or it can be because of some other reason. So, whenever we are thinking in terms of hyperthyroidism, the classical manifestation is what you need to keep in mind. If I just add more information in this question, मैं थोड़ा सा question को modify कर देता हूँ. Heat intolerance is there, weight loss is there, palpitations is there. The patient is also having the presence of ophthalmopathy, or the patient is also having the presence of pretibial myxedema. Big time hint in the exam question. We are dealing with thyroid overactivity plus ophthalmopathy plus dermopathy in the form of pretibial myxedema. Yes, I am now thinking in terms of autoimmune cause of hyperthyroidism, and that would be a condition that is going to be given the name of Graves' disease. pretty grave important fact that you need to remember in the exam. Why would they ask you about Graves' disease? Also is because of a histopath question which has been asked so many times commonly. You are having the presence of papillary formation over here because of the development of hyperplasia, increase in number of follicular cells. And as a result of overactivity of the follicular cells, you are going to be having a classical manifestation in these patients, which is going to be given the name of scalloping of the colloid. Scalloping of the colloid. So those whitish areas or the image that comes to immediately your mind of that having the presence of a follicle in which there is too much of a papillae formation and then overactivity of the cells, because of which you are going to be having the whitish areas suggestive of scalloping of the colloid, is what is seen as a picture of Graves' disease. The next one that we talk about is a patient which is exactly opposite of what we talked about just now. मतलब बिल्कुल ही उल्टा. That means patient को क्या क्या हो रहा है? Cold intolerance. Patient is having weight gain. Patient can be having the presence of menstrual disturbance. Patient can be having brittle hair. She can be having alopecia. She is having a low mood. She is going to be having hyporeflexia. So any of those terms, typically in a middle-aged female, yes, what I'm thinking in terms of over here is, now my patient is going to be suffering from a condition in which she is going to be having a development of hypothyroidism. Now, the moment I'm thinking in terms of hypothyroidism, I immediately would like to have two important differential diagnoses. First one can be that this can be because of a patient who is going to be having iodine deficiency. Very, very important, especially when we are thinking in terms of endemic hypothyroidism. The second one that we can talk about is autoimmune cause of hypothyroidism. An autoimmune cause of hypothyroidism means we are talking about an example of a condition that is going to be given the name of Hashimoto's thyroiditis. Hashimoto's thyroiditis. Now, when I'm talking about Hashimoto's thyroiditis, the hint in the exam question can be that there is an infiltration of the thyroid gland and there is presence of lymphoid follicles. The hint that I'm getting for iodine deficiency will be that multiple people in the same geographical area has been affected. So, depending upon what they give you as an additional information, you can be decoding it as per the information given in the exam. May I just remind you of the fact, if I am suspecting my patient to be having the presence of Hashimoto's thyroiditis, what is an example of an antibody that you would like to check in the patient? Very good. Hanji, bilkul theek. So, we are talking about hypothyroidism, and therefore, what these patients are going to be having is a presence of an antibody that is going to be given the name of anti-TPO antibody, anti-thyroid peroxidase antibody. Right? Because of this antibody, the TPO enzyme is not able to function properly. So, all those physiology things about the coupling, oxidation, and the formation of the monoiodine and the diiodotyrosine will not take place. That's the reason why the patients are going to be having a development of hypothyroidism. Right? Talking about the next one. Patient is having the presentation of either of them. They have been asked separately as an exam question. Either upon a tapping, there is a presence of a facial muscle spasm. So, that is what is being given the name of Schostek sign. Or the question will make a mention of the carpal spasm, in which the patients are going to be having a blood pressure cuff being inflated and the carpal spasm is going to be seen. That is given the name of Trocheus sign. So, this is what is suggestive of hyperexcitability, and that hyperexcitability is going to be contributed by the presence of decreased amount of calcium in the blood. And therefore, this is what is going to be associated with the development of hypocalcemia. Hypocalcemia. Another manifestation that we could be having of hypocalcemia, apart from the presence of Schostek sign and Trocheus sign, is patient could be having the presence of a perioral tingling or numbness. Now, typically, mark my words, typically, if the perioral tingling or numbness is going to be seen because of platelet donation, because of platelet apheresis, then this is going to be again contributed by the presence of hypocalcemia. Why would somebody have a perioral numbness and perioral tingling after platelet donation? Because the hypocalcemia over there is going to be induced by the presence of the anticoagulants at the time of the platelet apheresis. Right? That is what you just need to remember over here. The other important thing regarding Trocheus sign, please read the question exam carefully. There is another Trocheus sign that we talk about in neoplasia or in oncology, and that one would be the presence of migratory thrombophlebitis. So, two Trocheus, but name is similar, but the manifestations are totally different and therefore associated with totally separate conditions. That is what you need to remember. Talking about the next one. Patient is going to be having the presence of, is a known case of diabetes, typically type 1 diabetes. This patient comes to you in the emergency, and this patient is admitted in the ICU or the critical setup, and he is having the presence of a rapid, deep, labored breathing. Now, whenever you're having a type 1 diabetic patient having a labored breathing, typically deep and rapid, this means the patient is going to be typically an example of a patient who has gone into a complication given the name of diabetic ketoacidosis. Now, please remember the fact, what kind of complication do you associate with type 2 diabetes? You are going to be having the non-ketotic hyperosmolar coma. Type 1 diabetics are going to be having diabetic ketoacidosis. What is this particular type of breathing called as? Yes, you are very right. This type of breathing is what is going to be given the name of Kussmaul's respiration. This is what is going to be given the name of Kussmaul's respiration. Of course, you have a better idea than me that how do I going to be manage this patient? I'm going to be managing this patient with the help of what is given the name of the GKI drip. That is a glucose, potassium, insulin drip. Along with that, you have to infuse bicarbonate. Along with that, you have to give antibiotics, and that have to be given in a sequential fashion, which I'm sure most of you would be recalling from your knowledge of medicine. But that deep labored breathing, type 1 diabetic patient is what is going to be suggestive of Kussmaul's breathing. That is what you need to remember. The next one makes a mention of a patient who's going to be having the presence of the manifestations like skin hyperpigmentation. There is orthostatic hypotension. There is a presence of fatigue and weakness. The patients are going to be having weight loss. They can be having muscle aches or myalgias. There is a GI disturbance. And what can be seen as an additional finding is patients are going to be having increased ACTH, increased MSH. In fact, this is something which is a plus minus information. It may or may not be given. Combination of presence of malaise and fatigue, having the presence of orthostatic hypotension suggestive of low BP, having the presence of skin hyperpigmentation, big time hint, means the patient is going to be having some issue with the adrenal gland. And what kind of problem are we suspecting over here? Yes, I am suspecting the patient is going to be having the presence of adrenal insufficiency. So what I am dealing with over here is a patient who is going to be having the presence of adrenal insufficiency. Now, the moment I am thinking in terms of adrenal insufficiency and I am thinking in terms of orthostatic hypotension, malaise, would it be acute or would it be chronic? If I'm talking about skin hyperpigmentation, I am thinking in terms of a patient who is going to be having the presence of chronic adrenal insufficiency. What's the technical name that is going to be given to this condition? This was a previous NEET question, has been asked in the FMGE exam also. So this is what is going to be given the name of Addison's disease. Addison's disease. So why are the patients going to be having the presence of hyperpigmentation? What is the basis? The simple biochemical basis is that you are going to be having more formation of the precursors, because of which there is increase in the MSH, that is a melanocyte stimulating hormone, and that would be associating with the presence of the hyperpigmentation. This condition is not to be confused with other condition that we talk about, in which the questioner is going to be making a mention of a patient who has been already on steroid therapy, particularly a patient on glucocorticoid therapy. And what you find in this patient is that this patient is going to be having the sudden discontinuation of the steroids, or this patient is going to be having a weakness and fatigue. He was being given steroids for some time, and now the patient lands up in your emergency because he is in a state of shock, or the patient is going to be having the presence of an altered mental status, or the patient is going to be having the presence of vomiting, or he's going to be having abdominal pain. Now, withdrawal of steroids, this would be an example of what is going to be given the name of an acute condition. So this condition is what is going to be given the name of acute adrenal insufficiency. And acute adrenal insufficiency is an example of, again, an example of an emergency. It's an emergency or a crisis. The crisis of non-functioning of the adrenal gland. Therefore, it is given the name of adrenal crisis. So whenever I'm thinking in terms of Addison's disease, it's an example of a chronic adrenal insufficiency. But whenever I'm thinking in terms of adrenal crisis, I'm dealing with a patient who's going to be having the presence of acute adrenal insufficiency. The clinical manifestation and the clinical scenario in both these conditions is going to be radically different. Talking about the next one. The classical 3P condition. Tumors which are going to be seen in the patient affecting the pancreas, affecting the pituitary, affecting the parathyroid, and that would be just so easy peasy cheesy for you, because what I'm dealing with now over here is a patient who's going to be suffering from a condition that is given the name of MEN1 syndrome. MEN1 syndrome. So MEN1 syndrome, most of us are familiar, is what is going to be given the name of 3P syndrome. That means the pituitary, parathyroid and pancreas problem. What exactly is the technical name given to the MEN1 syndrome? That's an easy question asked in the exam. It is given the name of Werner syndrome. Recall the fact, we have talked about this so many times earlier, guys. Werner syndrome is an example of a condition in which the patients are going to be having premature aging because of the defect at the level of the DNA repair genes. But what we are talking about is a multiple endocrine glands being affected. ME is what is involved, multiple endocrine glands, and therefore that is going to be given the name of the MEN1 syndrome. The next one can be again easy, in which the patients are going to be having a combination of medullary thyroid cancer, in fact, associated with pheochromocytoma. So those two are going to be coexisting. The moment you think the both of them are coexisting, what gene problem comes to your mind? Red gene problem. Now, if the question makes a mention of patient also having the presence of a parathyroid hyperplasia, then we are thinking in terms of a condition that is going to be given the name of MEN2, or this is also being given the name of MEN2A syndrome. The MEN2 or the MEN2A syndrome is an example of a condition that is also being given the second important name of Sippel syndrome. So the combination of medullary thyroid cancer, the presence of pheochromocytoma, and the presence of parathyroid hyperplasia is Sippel syndrome or the Men-2A syndrome. Of course, the next one is easy for anybody to predict. If I'm going to be talking about the presence of medullary thyroid cancer, presence of pheochromocytoma, and the presence of 3Ms. 3Ms automatically means I'm thinking in terms of what is given the name of MEN3. MEN3. So it can be mucosal neuromas. There is a presence of marfanoid habitus. There is a presence of megacolon. That is what you need to remember. And therefore, I'm thinking in terms of a condition which is given the name of MEN2B, sometimes also being referred by the name of MEN3 syndrome. And MEN3 syndrome is an example of a condition. 3Ms are to be remembered. Again, I repeat, there is a presence of megacolon, there is a presence of mucosal neuromas, and there is a presence of marfanoid habitus. Now, don't look at your notes, but try to recall what was the type of lens dislocation that you were having in a patient suffering from Marfan syndrome. Was it nasal or was it temporal? Yes, you are very right. बिल्कुल ठीक बता रहे हो आप. Temporal था, and that was upwards. Where were we having the downward and the nasal presence of a lens dislocation? Yes, you are right. It was seen in a patient suffering from homocystinuria. So when we are talking about this condition, this is MEN3. That is what you need to remember over here. What is the gene involved in MEN3? Again, it's an example of a condition in which the patients are going to be having the problem at the level of RET gene. Whenever we are talking about a patient who's going to be having a presentation, in fact, this came in your NEET 2024 exam as well, cutaneous flushing, the patient is having diarrhea, the patient is having a bronchospasm, there is a presence of a right-sided cardiac murmur, and the patient can be having the presence of an additional finding. Now, may or may not be given, but combination of a patient having bronchospasm and diarrhea along with flushing should itself make you alert that what we are dealing with over here is a patient who's going to be having the presence of massive increase in the activity of serotonin. And that is what is going to be seen in a patient suffering from a condition that is going to be given the name of carcinoid syndrome or carcinoid tumor. So typically what is going to be seen in the patients is, this is an example of a tumor. Where is it going to be arising from? Yes, you know the answer, Argentafin cells or enterochromaffin cells. So my patients are going to be having presence of too much of formation of serotonin. Now, this tumor is going to be having a tendency, it is going to be present in the GI tract. From the GI tract, it is going to be going to the liver, metastasis. The metastatic cells or the cancer cells in the liver now secrete serotonin, which directly enter into the systemic circulation. And because it is entering into the systemic circulation, so the patient is going to be experiencing the combination of bronchospasm, flushing, and diarrhea. The same serotonin which is entered into the systemic circulation is going to get converted into, yes, friends, hydroxyindole acetic acid. And that hydroxyindole acetic acid is what was present in a high amount in the urine of the patient. So, independently, this has been an exam question. That's a biochemistry question. Otherwise, you need to think in terms of bronchospasm plus presence of diarrhea plus cutaneous flushing. We are thinking in terms of a condition that the patient is going to be suffering from a condition that is given the name of carcinoid syndrome typically, which is going to be because of the metastasis coming from carcinoid tumor. The next one that we talk about is a patient who is going to be having the presence of a combination of jaundice, and the patient is going to be having a palpable gallbladder, but this is going to be distended non-tender bladder. The moment you're thinking in terms of a combination of jaundice and the presence of a non-tender gallbladder, but it is palpable and it is big in size, what you're going to be thinking is in terms of a sign. And I hope that this is something that you have read in surgery, Courvoisier sign, right? Why do we talk about Courvoisier sign? This is a separate question because this is something that you associate with the patient having the presence of a cancer affecting the head of the pancreas. This cancer of the head of the pancreas typically is notorious for causing obstruction of the common bile duct. And there is going to be a distal obstruction of the common bile duct, as a result of which the patients are going to be having a distended gallbladder. Thankfully, it is an example of a condition which is going to be non-tender, but the bad point of the RNA is that it is suggestive of a cancer, and this cancer, of course, all of you know, friends, is not going to be having too good a prognosis. So that in general means that we are dealing with a patient who is going to be having a poorer prognosis. The next one that we talk about is going to be a patient who is going to be having a history which is typically suggestive of classically alcoholic patient who is going to be having the presence of, now it talks about the patient who is going to be having a history of alcohol intake, and he is going to be having the presence of a back pain or abdominal pain. And a lot of times, for most of the questions, they do make a mention of hematemesis being present. So blood coming in the vomitus. Patient is having a history of alcohol use, and the patient is going to be having the presence of abdominal pain or a back pain. That is what you just need to remember over here. And this could be also seen in patient in case of a psychiatric condition, which is going to be given the name of bulimia nervosa. So, you know, the patient is going to eat too much. Then they are going to be inducing vomiting, and that is going to be bringing the food from the stomach back in the form of a retrograde movement in the form of vomiting. Now, whether it is because of alcohol or because of bulimia nervosa, the fact is the patient is having the vomitus coming back, and this is what is going to be causing severe damage at the level of the lower part of the esophagus. In fact, there is a tear. What kind of tear are we talking about over here? Yes, what I'm talking about over here, guys, is an example of what is given the name of Mallory-Weiss tear. So whenever I'm going to be talking about this kind of a condition, the Mallory-Weiss syndrome or the Mallory-Weiss tear, this patient is going to be having repeated episodes of vomiting, because of which there has been a damage at the level of the lower part of the esophagus. Alcoholic patient, bulimia patients, remember them for this reason. The next one can be an example of a question which is going to be making a mention of patient having a dysphagia, which is sometimes mentioned in the exam question. Maybe it make a mention, ऐसा बोल सकते हैं esophageal webs थे, but they will make a mention of a patient having iron deficiency anemia. And the question is going to be making a mention of a patient who's going to be having the presence of a glossitis as well. Now, this has been asked in the exam relatively recently, at least 3 times in the last 4 years. Combination of iron deficiency anemia, glossitis, dysphagia because of esophageal webs. What are we talking about over here, friends? Yes, we are talking about an example of a condition that is going to be given the name of Plummer-Vinson syndrome. Plummer-Vinson syndrome. This is an example of a condition in which the patients are going to be having a high risk of development of cancer of the esophagus. But what is going to be the important feature of this kind of a cancer? This cancer is typically going to be affecting the upper part of the esophagus. So recall from what we have talked about in our main videos as well as in our mission videos and the quick revision videos. If I'm talking about achalasia cardia, my patient is at high risk of cancer. But which part of esophagus? Lower part. If my patient is having a history of Barrett's esophagus, again at high risk of cancer, but which part? Lower part. But this is an example of a condition in which my patient is having cancer of the esophagus, but which part? It's the upper part of the esophagus, which is going to be affected in the patient. And therefore, Plummer-Vinson syndrome is what you need to remember as an important fact for the exam. Because my patient is going to be having iron deficiency, तो इसको दूसरा नाम हम क्या देते हैं? Sideropenia. And because the patient is going to be having a cancer, because of which there is a difficulty in swallowing, so the other buzzword over here is sideropenic dysphagia. So these are the words which I wanted to remember, because this is what I've been calling by the name of the cerebral hum words. The more you know about these words, the higher is the probability of your cracking the exam with great scores. And of course, that increases our probability of catching up with each other at our wonderful event which takes place just to felicitate all of you wonderful achievers, that is cerebral hum. So these are the cerebral hum words that you just need to keep in mind from the perspective of cracking the question in the exam. The other thing, the exam question can be something as simple as a question which makes a mention of a patient having the presence of an enlarged, firm, left-sided supraclavicular lymph node. Now, left-sided supraclavicular lymph node is going to be associated with what name? Enlarged left supraclavicular lymph node is what is going to be given the name of Virchow's lymph node. Virchow's lymph node. What does Virchow's lymph node tell you? Virchow's lymph node tells me the fact my patient is going to be having the presence of a hidden cancer. It could be an example of a GI cancer, for example, stomach cancer. It could be an indicator in case of a male that the patient could be having the presence of a testicular tumor. What I want you to remember is other Virchows which are being asked in your exam so frequently. So one is going to be given the name of Virchow's pride. You know Virchow's pride? Of course you know. ये तो हमें पता ही है. Virchow's pride is what we talked about, guys, in association with clot formation or thrombus formation. The best of you will remember it. So there is a presence of stasis, there is a presence of turbulence, there is a presence of endothelial cell injury, and there is a chances of blood hypercoagulability, because of which the patients are going to be talking about Virchow's pride. Where do we talk about the presence of Virchow-Robin spaces? Virchow-Robin spaces will immediately come to your mind because of which organ do you think is going to be associated with Virchow-Robin spaces? Virchow-Robin spaces associated with. You are applying your mind. That's the answer. They are present in the brain. And if I'm talking about Virchow's lymph node, this is what I just need to keep in mind over here, that enlargement of the left-sided supraclavicular lymph node, typically in a patient suffering from gastric carcinoma, that is what is to be remembered. If it is a patient who is going to be suffering from a testicular tumor and he's going to be having this kind of an enlargement of the lymph node, what is the sign which comes to your mind? That's given the name of Troisier's sign, right? Talking about the next one. You can be having a question which is going to be talking about the patient having the presence of a GI bleed. Now, I just want you to be very cautious when you're dealing with such questions. You see, first way of looking at this question is patient is having the presence of blood in the vomitus, hematemesis. Or the patient is going to be having the presence of melena. What is melena? The patient is going to be having the presence of dark colored stools. Dark colored stools. Now, typically, this is suggestive of the fact that my patient is going to be having the presence of an upper GI bleed. What's the anatomical definition of upper GI bleed? The bleeding has taken place proximal to, very good, ligament of Treves. So, if this is hematemesis, blood coming in the vomitus, or if this is going to be melena, that is dark colored stools, because the acid is now reacting with the blood, this is suggestive of upper GI bleed, and this is what is going to be seen typically in what category of patients? Peptic ulcer disease, right? However, if the question makes a mention of fresh maroon blood, fresh blood coming in the stools, that is called as hematochezia. So, hematochezia is what is going to be suggestive of the presence of lower GI bleed. Now, if I'm thinking in terms of something like a lower GI bleed, what is the thing which is going to be coming to your mind? It could be a patient who could be suffering from a condition, say for example, hemorrhoids, right? Or it could be a patient who could be suffering from a condition like diverticulosis. I hope you remember about colonic diverticulosis. So, differentiate between upper GI bleed and lower GI bleed in the exam. Lower GI bleed is going to be hematochezia. Upper GI bleed is going to be dark color stools, melena, or the patient is going to be having hematemesis. That is what is to be kept in mind. The next one that we talk about is combination of arthalgia, diarrhea, cardiac and neurological symptoms. Now, we are talking about joint involvement, GI involvement and CNS and cardiac involvement. What comes to your mind? I'll drop a hint for you. This is going to be an example of a very classical malabsorption disorder. Yes, now you are able to think in terms of the disorder. ये हमें अचानक से याद आया कि अच्छा कौन सा malabsorption disorder था जिसमें joint involvement भी होता है, जिसमें cardiac और neurological involvement भी हो सकता है. We are thinking in terms of a condition that is going to be given the name of Whipple's disease. What is the causative organism, guys? It's a bacteria that is given the name of Prophylema whippleyi. The important related pathology question from this is, there is a presence of PAS positive macrophages which are going to be present, and these macrophages contain a lot of bacteria. So, presence of rod-shaped bacilli or presence of PAS positive macrophages which are going to be present in the lamina propria, and this is something which can be seen on the histological examination on the biopsy in patients who will be having Whipple's disease, right? What is the significance of knowing about the joint involvement? Typically, joint involvement is an early manifestation. What is the significance of knowing about the CNS involvement? CNS manifestations and neurological symptoms are typically late manifestations in case of Whipple's. Why am I stressing upon Whipple's in so much of detail? It's the only example of a malabsorption disorder which is seen because of defect in the lymphatic transport. The rest of all conditions are going to be seen contributing to malabsorption because of other reasons, but the only one because of a defect in the lymphatic transport is this one, that is Whipple's. Because it is a bacterial cause, obviously it is going to be having a relatively better response with administration of antibiotics. That is what you need to keep in mind, right? Talking about the next one. You could be given a straightforward question which is going to be making a mention of the Ropsing sign, which means the patient is having a right lower quadrant pain, especially when you're going to be having a palpation of the left lower quadrant. So imagine you're pressing the left lower quadrant, but the patient experiencing pain on the right side. Now that is because of the increased abdominal pressure causing the pain on the right side. Or the other can be that we ask patient to take a deep breath and then the patient again experiences a severe right lower quadrant pain. This is what is being termed as the McBurney sign. So when you press the left lower quadrant and there is a pain experienced by the patient in the right lower quadrant, that is a Ropsing sign. And if I'm talking about the presence of the patient experiencing the pain in the right lower quadrant on the deep palpation, this is what is going to be associated with the McBurney sign. Where do we have it? Right lower quadrant pain. Of course, the first thing that is going to be coming to your mind is going to be, this is something which a very basic first year student also knows, because this is what is going to be the applied aspect of it. This is what is going to be seen in a patient suffering from acute appendicitis. Acute appendicitis. Read the question carefully, guys. You're not supposed to confuse Ropsing sign with something else which is being asked in the exam, that is a Ropsing's procedure which you're going to be doing for the cystic disease, right? So Ropsing sign, palpation of the left lower quadrant, pain on the right side, and deep palpation is going to be associated with the severe right lower quadrant pain. That is what you need to remember. McBurney sign. Ropsing McBurney sign associated with acute appendicitis. That is what you need to remember, right? The next one talks about a patient having the presence of hamartomatous GI polyps. The bread and butter of GI questions in the current times, hamartomatous GI polyps. If the question makes a mention of the presence of hyperpigmented macules on the mouth, on the lips, on the hands, on the genitalia, what are we dealing with? Without a doubt, we are dealing with an example of an autosomal dominant condition. What condition comes to your mind? Hamartomatous polyp, hyperpigmentation of the macules in the mouth, lips, hands, and genitalia. Yes, we are dealing with a patient who's going to be suffering from a condition that is called as the Peutz-Jeghers syndrome. What's the problem in a patient who's going to be having Peutz-Jeghers syndrome? My patient is at high risk of development of a bowel obstruction because of interception. And more importantly, the patient can also be having a high risk of development of different types of cancers, which can be including gonadal cancer, which can be including bowel cancer, which can be including pancreatic cancer, which can be including breast cancer. All those things are to be remembered. So I hope most of you remember the fact that PJ syndrome. So my patient is going to be having P and J. Write it in the inverse fashion. Ulta likh lijiye. So the patients are going to be having the presence of the polyps. The polyps are going to be present in the jejunum. So jejunal polyps. And the second thing that I want you to remember over here is P for pigmentation. This pigmentation is what is going to be seen in the patients. So jejunal polyps, pigmentation, hamartomatous polyps, and the important histopathological link over here, what is going to be the biopsy finding of this kind of a polyp? It is going to be associated with the presence of the branching tree pattern, the smooth muscles arborizing into the lamina propria. That is what is to be remembered. What is the other important example of a polyp which they ask you in the exam, and hamartomatous polyp? This is an example of a polyp which is going to be seen in case of a child presenting with rectal bleed. And that polyp in which you have a hamartomatous polyp, child is presenting with the rectal bleed, is given the name of, yes, you are right, that is what is going to be given the name of juvenile polyposis. So jejunal polyp is Peutz-Jeghers. Juvenile polyp is something that is seen with child having the presence of a rectal bleed, in which you are having the presence of the mucin-filled glands, and there is presence of infiltration in the lamina propria. So that is what you just need to keep in mind. Talking about the next one, you're going to be having hundreds and thousands of colonic polyps, and the question is going to be making a mention of osteomas. It could be making a mention of soft tissue tumors, and it could be making a mention of this important cliche thing: the patients are going to be having the presence of impacted or supernumerary teeth. So presence of colonic polyps, and what kind of polyps are we talking about over here? Of course, adenomatous polyps in combination with soft tissue tumors, in combination with osteoma, in combination with the dentition issues that can be supernumerary teeth or impacted teeth. With what we are dealing with over here as a patient who's going to be suffering from a condition, as we have talked about it so many times, multiple tumors, as if you have come to a garden and you're looking at the tumors, showing you their variety, that is going to be given the name of Gardner syndrome. Immediately what will come to your mind is Gardner syndrome is going to be a variant of what is given the name of familial adenomatous polyposis. Can we just have a quick recap, guys? Classic FAP is going to be having only the presence of more than 100 adenomatous polyps, along with the presence of ocular issues, retinal pigment epithelial hypertrophy. If I'm talking about Gardner syndrome, you are having FAP plus osteoma plus soft tissue tumor plus impacted teeth. If I'm talking about something like Charcot syndrome, you are having the presence of FAP along with the presence of CNS tumors in the patient. Those are the things that we just need to recall over here. The next one is going to be patient who's going to be having the presence of a severe jaundice, typically a child, that means a neonate pediatric question, and he's having the presence of kernicterus or neurological changes, which is going to be seen in the child. Now, jaundice in a child with kernicterus is suggestive of a severe level of jaundice, and typically that can be associated with multiple reasons. But one of the important syndromes because of which the patient is going to be having this is what is going to be given the name of Crigler-Najjar syndrome. Crigler-Najjar syndrome. Now, I would like you to recall the fact that if I'm talking about Crigler-Najjar syndrome, this is going to be having two variants. First variant in which there is absence of enzyme activity. The UDP glucuronide transferase is just not there. First one, enzyme is totally absent. And the second one in which you are having enzyme, but it is underactive. Now, if it is a situation where the enzyme is underactive, can I give a pharmacotherapy for useful or which can be improving the condition of the patient? The answer is yes. You can be giving enzyme-induced drugs like phenobarbital. But if I'm going to be talking about a situation in which the enzyme is just absent, unfortunately, I'm not able to do anything about this child, and a lot of these children are unfortunately going to die. Also, with respect to pharmacology question, beyond phenobarbital, what I would like you to understand over here is which category of antibiotics are to be avoided in children, again for the reason that they can be responsible for development of kernicterus in a child. The antibiotics which are going to be having the presence of a high plasma protein binding, typically I want you to remember about the sulfur drugs. Sulfur drugs or sulfonamides are to be avoided in case of children because of this reason, and that's what they have asked you in the exam 3 times, guys. People tend to forget this. Don't take it so lightly. Sulfur drugs are going to displace the bilirubin, and therefore this bilirubin is easily able to cross the blood-brain barrier. What type of bilirubin I'm talking about? I'm talking about the lipid-soluble bilirubin. I'm talking about the unconjugated bilirubin, which is going to be displaced by the sulfur drugs, and that can be causing deposition in the basal ganglia. That can be causing a permanent, irreversible neurological damage, which is going to be given the name of kernicterus. So keep that in your mind from the perspective of an exam question. The next one is going to be fairly easy when it talks about the presence of a patient who is going to be having the presence of liver dysfunction along with golden brown rings around the peripheral cornea. And typically, this is going to be an example of an image-based question. So we are talking about or dealing with the Kayser-Fleischer ring. Of course, the moment I'm thinking in terms of a Kayser-Fleischer ring, I'm talking about excessive amount of copper. And the moment I'm thinking in terms of excessive amount of copper, I'm dealing with a patient who's going to be suffering from Wilson's disease. Now, Wilson's disease, I would like you to recall from the perspective of a biochemistry path question, is going to be an example of an issue at the level of ATP7B. And this is what is not to be confused with the problem at the level of the ATP7A, which is an example of Menkes disease. What's the other problem that you are having in Wilson's? My patient is having a liver issue. My patient is going to be having the presence of an eye issue. My patient is going to be having the presence of neurological manifestations affecting the basal ganglia, including Parkinsonism-like manifestations, right? And the other important finding, apart from the Kaiser fleshering in a patient having Wilson's, is my patient can be having the development of a sun plaque activity, right? So just keep in mind that it is a copper overload condition which is to be remembered over here so far as Wilson's is concerned. Of course, you are familiar, the ATP7 gene, where is it located? It is going to be located on chromosome number 13. The next one is a fairly easy thing that we read in the clinics. For a female who's going to be obese, she is fat, fertile, he's having multiple kids, 40, fat, fertile female, fat, fertile, fair female of 40, who's going to be having history of fasting or no food intake typically. So she is going to be having either, sometimes the exacerbating factors can be patient on total parenteral nutrition, that means she's fasting, or the other important thing which you are observing now with a lot of these drugs available which are promoted because they can be responsible for causing rapid weight loss is going to be the fact. So these are going to be typical, what we were traditionally calling as the 4 or 5 Fs. Now it's been extended, fat, fertile, female of 40. They've added the word fair, they've added the word fasting. They're talking about something like a patient who's not feeding. And therefore, this is going to be seen in a patient who's going to be suffering from cholelithiasis. What you're dealing with over here is a patient who's going to be suffering from gallstones. What can be the important questions asked in the exam? Of course, they can be asking you the different subtypes of gallstones could be having the different subtypes of etiological factors. For example, the commonest type of gallstone that we are having in the Indian population, that is going to be an example of a mixed stone. What kind of specific gallstones will come to your mind if I'm dealing with a patient having a history of chronic hemolysis? I will be thinking in terms of a patient who's going to be having pigment gallstones, right? So those are the basic facts that you just need to keep in mind so far as the concept of the fat, fertile, fair female of 40 is concerned. Of course, not to forget about the rapid weight loss stuff, which is going to be asked in the exam, right? So these were the example of some of the important keywords or the important clinical presentations which are given in the exam. Provided we are aware about these things, my friends, you are going to be having a smooth walk in the exam, because remembering and revising these keywords, or what I again call by the name of the cerebral hum words, will ensure that even if you are not able to directly recall and understand all the long history that they give in the exam, these are going to be helping you in the exam for a rapid assessment of what is the likely diagnosis in the patients, right? Till the time we catch up in the part 3, take care of yourself.